Hello and welcome to the Menopause and Cancer podcast. My name is Danny Binnington and a really warm welcome to our series of HRT after breast cancer. I'm the host for the Menopause and Cancer podcast, and I'm also the founder of the Menopause and Cancer not-for-profit organization where we support all cancer survivors who are struggling with the menopause after their cancer diagnosis. Over the last few years of having spoken to thousands of people and really engaging in this conversation, many of you have said, I really want to know about my own risks versus benefits of using HRT after my particular type of breast cancer. And I also know it's a really emotive and a really controversial conversation, and many people shy away from having it. But I really want us to have this conversation because I think, and I know there are so many of you at home feeling very alone, very isolated with their worries and their fears, not knowing where to go for information. And so we've put together this HRT after breast cancer series. On episode 1, we had breast oncologist Dr. Leila Agrawal on the podcast to explain to us all of the studies, the trials that have been done looking at the use of HRT after breast cancer. On episode 2, we were speaking to Professor Richard Simcock, another oncologist, who talked about the risks. What are these risks? Who holds the risk if HRT after breast cancer is prescribed? Is it the doctor? Is it the patient? And we also talked about how can we move forward when the evidence we have is old, when the preparations that have been used isn't what we would use today, when the amount of women that have been studied is relatively small, and when there was conflicting outcome from all of the trials that we've had. So he talks about how we can move forward. And today on this conversation, I want to invite a patient and a doctor who has decided to use hormone replacement therapy after her own breast cancer diagnosis. She was diagnosed with a hormone-positive breast cancer. This woman is Dr. Tina Peers, and Dr. Tina Peers, to me, is a true women's health specialist. She started as a general practitioner back in the 80s. Then she became a consultant in contraception and reproductive health. And then later she expanded her knowledge and worked with people in the menopause. And she also is a doctor, a colleague of Dr. Nick Panay, whom she met working at the Chelsea and Westminster Menopause Clinic, where she saw a lot of complex cases. Many people came to her and came into the Chelsea and Westminster Clinic who were after a breast cancer diagnosis and who are curious about the use of HRT. So we also want to talk to her about the clinical setting. How does it work if you go and see a menopause specialist? How can the conversations go? And what were her thought processes of starting hormone replacement therapy? This is a really riveting conversation. We talk about a lot more than just HRT and her decisions. We talk a lot about women's health, how underserved we are, and how complex we are as amazing people, as amazing bodies, and why this is a complex conversation. And I'm very grateful she's here to talk to us about it all. So let's welcome Dr. Tina Peers onto the show. Thank you so much for giving us a little bit of your time, Tina, and welcome to the podcast.
Oh, well, thank you so much, Danny, for inviting me.
We've already chatted and it's been so amazing to talk to you and hear a little bit about your professional and personal experience. And I want all of our listeners to now invite them into your story because it's quite an incredible story. You gave up working as a GP in general practice because you felt you didn't do justice to the patients you saw. Can you tell me a bit more about that?
Yes, well, as everyone knows, the GPs are incredibly busy and there's a huge time pressure. So in the practices I worked in, the appointment times varied from 7 minutes per appointment to 10 minutes. And I found it was absolutely impossible to do anything worthwhile in that time. It was really difficult. To really listen to people and give them your proper attention takes much longer. So I was always running late and always stressed, which was not a very easy work life. And I also felt that we weren't addressing real issues properly. It was very much about just giving them a prescription often or referring them on to somebody else. And there wasn't time to talk about some of the things that were obviously influencing their their symptoms and their disease processes, such as their mental health and their lifestyle, exercise, diet, nutrition, etc. And so I found it very unsatisfactory. And I developed an interest in women's health at the same time. So I used to see an awful lot of the women in the practice. And I also started doing some contraception clinics, which I just loved because I had 20 minutes, 15 minutes with each patient, and it was so much better. And so in 1994, I gave up general practice completely and was asked to run the contraception services for East Surrey, which I loved doing. And then I was asked to take over mid Surrey in 2002, and then the whole of Surrey in 2005. And so I did that work for 24 years and developed an amazing team of people. And we provided fantastic young people's clinics and, well, for all ages of women who needed sexual health advice and care. And it was great. At the same time, I developed a real interest in menopause, really from my GP days. I was doing that. And I was a member of the British Menopause Society for many years. I then went to the Chelsea and Westminster Hospital and worked with Professor Nick Panay. And I was there for over 4 years, I think. And we ran I was working in the big menopause clinic there, which is fantastic. I still work with Professor Panay in his private practice called Hormone Health. And I have my own practice now called the Menopause Consultancy.
At what point in your clinical journey as a doctor were you diagnosed with breast cancer yourself? Put me into that time frame. Where were
Yes.
you at?
So it was in 2004, and I was working in contraception and women's health. And I also had a private practice at that time. So I was seeing a lot of women for HRT as well. And
Okay.
that's when I found a breast lump and realized immediately that I had cancer, breast cancer. Yeah.
Okay, but I want to put that into context for everyone listening. This is a long time before anyone was talking about the menopause in the UK. So we're going to, so let's say the last 5 years, the menopause, conversation has exploded. I don't think I'd be being here having this podcast and, doing our not-for-profit if it hadn't been for everyone else really pioneering in this menopause conversation. Because of these women, I realized, oh my gosh, I need to do something about my imminent removal of the ovaries. How am I going to
Mm.
manage it? Who's going to help me? How am I going to live well into my bones, into my heart health and bone health when I'm 60, 70, and 80? But you did that a long time before. You worked in menopause. What were you told as a youngish, early 40ish, you were in your early 40s patient that knew a lot about hormones? What were you
Yeah.
told to do?
I was at that stage, it was all about having treatment for the breast cancer. So it
Of
was a
course.
lumpectomy, and they did the sentinel node. They took out 3 nodes. And at that stage, when you had a micrometastasis in one of the nodes, they went in and did a clearance and took out more. Now they know that if it's a micrometastasis, which means if it's less than, I think it's less than 1 millimeter, then it's not going to be an issue and they don't need to go in and take more. But they were gathering the data in those days. So I suppose that's why I ended up having a clearance, because I had one micrometastasis that was 0.9 of a millimeter. And that was the worst operation, actually, because it was very difficult when they took out 19 lymph nodes from my axilla. So I only had,
Yeah.
so you had the same. So I had,
Same for me.
yeah. So I was left with, I think, 11 lymph nodes in my axilla rather than 30, something like that. And then I had radiotherapy. In those days, it went on a long time, the radiotherapy. It wasn't like a 5-day course. It was every other day for weeks and weeks and weeks, and with 5 days at the end where they gave you a more concentrated dose. And then they said, right, now we want you to go on tamoxifen. And there wasn't very much discussion, to be honest, about the risks and benefits of tamoxifen. I was just told, they kept saying, and they really meant well. I'm not criticizing them, but in, I suppose, the knowledge at that time and what their all the oncologists were saying, etc., was it reduces your risk by 50%, so you must take it. And I was like, okay. And when you've just been through all of that, you're quite frightened. You know, my children were young. I had three young children. My
Mm.
youngest was 13. And I was thinking, God, I've got to be here. I've got to do whatever it takes to be around, you know. And so I started taking it. I didn't like taking it, if I'm absolutely honest, because I was very scared about what it was going to do to me. And knowing about hormones, I didn't want my hormones being switched off. I wanted to have my estrogen and the protection that I was telling so many women about, I was going to sort of lose. And I also didn't like taking a tablet every day that reminded me that I'd had breast cancer, because I felt I no longer had breast cancer. It was gone and I was fit and well, but I was taking this tablet. Anyway, I didn't do very well with the tamoxifen at all. I was okay, to be honest. I was okay for the first 4 months. I had my period still, I had my libido, I felt fine, it was no problem. And then suddenly it's sort of really switched off my estrogen and my period stopped. I started getting hot flushes, I couldn't sleep, I was irritable, I was tearful, I started crying a lot. I would spend weekends crying. It was terrible. Um, and and sort of putting on a very brave face at work, but actually just felt absolutely rubbish. And then I started to feel suicidal, which was really alarming. And I've never ever felt like that. And I'm always cup half full person, and enjoy my life and people around me and everything. But it was terrible. I was really, really thinking about doing something serious, and that really scared me, and that woke me up, if you like, to what was going on. And it made me think, stop being so busy at work that you can't think. Think about this very carefully. If I was a patient coming to see me, what would I say? And I would say, stop the tamoxifen. And so I stopped it. And within 3 days, I started to feel better. And then my periods came back, my libido came back. I mean, I really felt when I was on the tamoxifen like a non-person. I felt like I didn't exist. It was really strange. My whole personality, my my femininity, everything just went. But it came back, which was lovely. And then I went to see the oncologist, who said, okay, so you're more interested in quality of life than longevity.
Oh,
And
wow.
I know. And I said, yes, actually, I am. And that was all he said. And then I went to see the breast surgeon.
Can I
Yeah,
will, can I stop you there for a moment?
yeah,
Because that is quite a heavy statement, isn't it? That
yeah,
means that is
yeah,
quite a lot to take. I mean, I know
yeah.
as a doctor, and we're going to talk about your rational brain and all of the research you have done and all of that. But if
Mm.
I just hear that as a patient, that is
Oh,
terribly scary for me.
yeah,
So to hear that, that would frighten me to the core of myself.
yes.
How did you
Well,
how did you feel? Could you unpack it?
yeah, it was frightening, but I just had this gut instinct that it wasn't right. I just felt that he didn't really know what he was talking about, and that he just was following the narrative rather than questioning anything. And I'm very much a critical thinker. I like to think and analyze and research and think for myself. And I don't just accept what I'm being told as being, the right thing, or I have to prove it to myself that I feel it's the right thing. So when he said that, I was shocked that that's all he had to say. And I just felt quite sort of determined that yes, I did want quality of life, because I felt, I had young children, I had a busy job, I had lots of responsibilities, and I had to be able to function. And so my quality of life was absolutely paramount. Anyway, then I saw the breast surgeon, and um, he said, well, he said, okay, that's interesting that you've done that. And I said, well, it was just so awful, I couldn't take another tablet. I said, can you tell me, everyone keeps telling me that it reduces my risk by 50%, but what is my risk? Nobody had told me what my risk of recurrence or of death from this cancer diagnosis was. And he said, okay, let's look on the internet at a website called Adjuvant Online. I'm not sure it's still available. I think people use Predict now, but it
Yeah.
was Adjuvant Online then. So we went on to Adjuvant Online. He put in my age, my state of health, which was very good, the size of the tumor, what kind of breast cancer, any lymph nodes, all this sort of thing, into the computer. And it said that if there were 100 women exactly like me, there would be 4 deaths in 10 years in that 100 women. That's what they would expect. But 0.4 of those deaths would be from the cancer, and 3.6 deaths out of 100 would be from something else, an accident or other diseases. So I was like, okay, so it's only 0.4 of a death in 100, in 100 women in 10 years from the cancer. And I said, well, and that was without tamoxifen. And then they put in with tamoxifen, and it was the same. So taking tamoxifen for me and my particular cancer wasn't going to change the risk of death at all. And then I said to him, well, that's a no-brainer, isn't it? Because on the tamoxifen, I was going to definitely top myself. So I wasn't going to get to live to 10 years. And so, this is fine. So then he said, well, let's look at the recurrence risk. And they can't, they generally have a sort of a broad spectrum of recurrence. So you could have a low recurrence, which for me would have been 6 in 100. 6% recurrence, and a higher risk would have been at the most 9% recurrence if I was on the tamoxifen. But if I wasn't, it was double that. So that's where that doubling and halving came into it. So therefore, my risk of recurrence not on the tamoxifen was 12% to 18%. So he worked that out for me. And I said, well, okay, so that means 82% chance of no recurrence is the worst case scenario. Okay, so I prefer to look at it that way around. And he said, no, you're right. Yes, it is 82% chance of no recurrence. And I said, and I'm going to be screened, aren't I? And he said, yes. So I was being screened regularly, and I was being very vigilant with self-examination and so on. So I said, well, so we'll catch it. If something happens, we'll catch it. And I would much rather not take the tamoxifen. So we agreed that that would be the course of action. And I felt great for 3 years. And then when I was 48, I started to feel like I was on tamoxifen again, which was actually the perimenopause. And I started to get all the symptoms. And at that point, Danny, I was in denial because I was scared. I thought, I'm giving HRT to all these women, and they're enjoying it, and they're healthy, and they're fit, and I can see it transforms their lives. And I'm not going to be able to take it, and I'm going to feel like this. So I was sort of trying to delay any decision and thinking about it. I was just sort of busy, busy, busy. And then I went to this fantastic conference, Women's Health Conference in Venice, in this beautiful conference center. And this German professor gave a lecture, and the lecture was Women Post Breast Cancer Taking HRT. And I thought, this is for me. Absolutely fantastic. And he put up a list of 30 symptoms that women will be very familiar with at the perimenopause. And I ticked virtually all of them. I sat there and just sort of thought, oh, I have to face this. I have to do something about this. So afterwards, I went to, and he talked about the Stockholm study, which you'll be very familiar with, and he talked about the habit study. Anyway, I went up to him afterwards, and I introduced myself, and I asked him who I could speak to really help me make my decision. And he mentioned a lovely gynecologist in Sydney, in Australia, called Dr. Barry Wren. And he said, speak to Barry Wren. So I did. And Barry Wren was fantastic. He was just superb. He sent me all his research, and he had given literally well over 1,000 women post breast cancer HRT, and he had lots of results from the data showing that they didn't have an increased risk of recurrence or death, and that they were all sort of doing really well on their HRT. So we became very good friends, and he said to me, look, you don't have breast cancer anymore. You've been treated. It's been removed. So you should absolutely, you can go on to HRT. So I started it and started to feel fantastic. In fact, it's quite funny. I started it at the conference. So one of the doctors with me there, I was talking to her about it. She said, "Oh, I've got some Sandrina. I'll give it to you. You can have it
Oh my
back."
gosh.
And I thought, I said, "Oh, please." And I stuck it on my leg and I went to bed. And for the first time since 2004, I slept through the night. It
Mm.
was just extraordinary. I woke up in the morning and I thought, oh my God, I slept. That was amazing. And it was just because I'd had 1 milligram of Sandrina.
But there is so much to unpack. We all, as patients, we always think you doctors, you've got it all together, but you're not. You're as crazy as anyone. And I know that because I speak to so many of you and I love you for it. It's just wonderful to connect with all of you on that sort of personal level and to hear about your story. But there is a lot to unpack. You had to take your thinking and your critical thinking all across the world to a professor in Australia when you were working as a menopause specialist here in the UK. I know you've become the patient as well. What did your peers say here? Did they say, Tina, this is crazy. It's going to make your cancer come back? Or did you not even discuss it with any
I
of your peers here?
I didn't really discuss it with them because, but I did discuss it with my GP who refused to prescribe it for me.
Okay.
And so at that point, I then had to go to Professor Nick Panay and talk to him about it, and he prescribed it for me. And he was I knew him through the British Menopause Society, which I was a member of, and that's how we became great friends. And he really, really helped me. So I became his patient, and he prescribed. And I even wrote a letter to my GP saying, this is my, this is all. I sent her a big file with all the studies that Barry Wren had sent me, and a letter saying that based on all of this data, I have decided I want to be on HRT. I don't see that it's increasing my risks, and I'm happy to take full responsibility for that. But she still refused to prescribe, which was
Mm. So
disappointing.
I
Mm.
I always think it's very interesting, isn't it? Because when we choose to have chemotherapy, we sign, give a consent that we're going to embark on this treatment. We choose to have operations. I chose, for example, to have a port fitted when I had my chemotherapy. And I remember in the appointment that I was told there is like a 2% risk or something very tiny that your lungs could get ruptured. But it's nothing I ever thought would happen, but it happened to me.
Oh.
So I woke up in the middle of the night with my left lung totally deflated, and I ended up in intensive care for a long
Gosh.
time because there were complications. But it was part of that consent. And so really we're always allowed to make a choice. But what I'm hearing from so many people when it then comes to quality of life, whether that is vaginal estrogen, whether it's systemic HRT, whether it is other things, that choice is taken away from us. And it's an interesting thing
Mm.
how doctors sort of allow one side to make that risk, but not the other side, isn't it? Because what
Yes,
you were
it
saying
is.
is you were happy to carry that risk. And
Yeah.
I'm just trying to understand it from all different sides, really. Because,
Yes,
yeah.
and it's illogical. It is illogical. You're absolutely right. But anyway, so yeah, so I did get onto the HRT and I felt fantastic really quickly. Actually, I mean, women will testify to that
Mm.
when they go on to get their hormones replaced. It's wonderful. So yeah, so then I just went from strength to strength until in 2014, I was just getting dressed and I felt a tiny little lump on the side of my chest, literally under my axilla, not a lymph node, it was on my ribs. And it was tiny. And I knew immediately that that was another cancer. And I'd had a mammogram, which was clear, but I could feel, obviously the mammogram couldn't get, this wasn't particularly in very much breast tissue. And so I contacted then the most amazing plastic surgeon who was a dear friend. That's Mr. Harris and Paul Harris, and it was at the Marsden. He still is, I think. And
Yeah.
he's incredible. And he said, "Okay, we'll sort you out." And I said to him, "Well, actually, I want bilateral mastectomies." And he said, "Oh, okay, that's not normal." I said, "Well, I don't want to live with the risk that I could get another one in the other side and worrying about it." And I said, "I can't live without my HRT, so I have to be on my HRT. And I think everyone will feel more comfortable if I don't have any breast tissue at all, and I can take my HRT, and I can relax and be fine." So he agreed. And within 2.5 weeks of finding that breast lump, I'd had my bilateral mastectomy, and I then had my ovaries removed. at the Marsden, and that was it. And then no follow-up, no problems at all, absolutely fine. And I was off the HRT for about a week, because once I'd got the biopsy result and I knew that it was estrogen receptor positive, I thought, well, I shouldn't really be taking estrogen to feed it, so I'll stop. But my operation was the following week, and I took estrogen to the hospital so that as soon as I woke up from the operation, I could use it. And that's what I did.
So in terms of sort of what sort of makes sense for the lay patient like myself, you sort of think, okay, this lady has had an estrogen positive receptor cancer.
Yeah.
Wouldn't you, in your head, kind of like want to do everything to strip your body of any estrogen?
No.
That's sort of what we think,
Yes.
isn't it? Do you know
Yes.
what I mean?
Yes.
That's sort of what we think. And that's what
Yeah.
treatments like aromatase inhibitors and all of those do. And I wonder, so
Mm.
what's your thinking there, or
Mm.
what am I not sort of
Mm.
getting at the
Yeah.
moment?
So my thinking was that I had obviously studied the HRT and its risks and benefits for many years, because as a GP in the 90s, I was seeing a lot of women for HRT. And I knew all the benefits were proven, and my clinical experience was showing me all the benefits were massive in women and in their lives, their quality of life. So it's not just about stopping you have hot flushes. We know that it reduces all the symptoms, but we also know that it improves your cardiac health by 40 to 50%. We know that it prevents hip fractures by 30 to 50%. We know that it reduces cognitive decline by 45 to 70%. And we know it increases longevity by 3 to 4 years, but it's good quality longevity if you're feeling well and you're fit and healthy. It also reduces colon cancer by 30%. So I knew all of that, and that was sort of very much at the forefront of my mind whenever I have a discussion about HRT with any patient, including myself. So I know that how valuable estrogen is in the body, and the idea of doing something really sort of premenopausally that was against nature, really, to switch it all off, seemed to me to be the wrong thing to do. I much prefer to work with nature and to be logical about the approach. And I think when you also consider that women who've had very, very young women who've had breast cancer can go on to have pregnancies where their estrogen levels are really high, and they don't have an increased risk of recurrence or death from the breast cancer. And so, estrogen isn't, I just believe that estrogen wasn't as bad as people were thinking and believing it to be. And I concentrated very much on the positive side, without being, flippant or unaware of the dangers or potential risks. So,
Uh, I wonder if 100 oncologists across the country, how, some know a lot more about the menopause and some less. Many are more interested in how their patients survive, and others just say, take this little white pill for 10 years. Most people do fine. There
yeah.
is very few side effects. We know that's not true, but we know still many people prescribe that. And just week, I had a lady in our community who had her ovaries removed. And she said at no point did anyone speak to her about the menopause. And so we still know the devastation that happens out there on a single day. But dare I say, if 100 oncologists were listening to our conversation right now, they would worry. They would worry about even the possibility that we're discussing that estrogen might not be so bad when so many of their treatments, like aromatase inhibitors, are sort of stripping women's bodies, whether they're worried that they don't have enough time to have these difficult conversations with their patients, that they perhaps are not well equipped. They might not know all the studies like you do. Where do people go, and how do we have these difficult conversations? Because when I hear people talking at chat forums, one name gets mentioned, and that's a book by Dr. Avram Blooming, Estrogen Matters. So people talk about that, but people don't talk about other studies or how can they come to a conversation decision? How do
I
we do
think,
that now?
well, you're absolutely right. Dr. Avram Blooming is amazing, and it was his book that I read that actually Barry Wren recommended that I should read. So I got that immediately. And in that book, he describes many of the studies, and he unpicks them for people because, it's not reading and analyzing studies isn't everybody's forte, and it's not necessarily straightforward. And sometimes what you read in the study is a misinterpretation of the results of the study. And so you can't just take it at face value. You have to really know how to drill down and analyze it. And more recently, in 2022, in the Cancer Journal, pages 183 to 190, there is a very, very good review article by Avram Bluming, and it's HRT after breast cancer. Is it time to reevaluate?
Yes.
And that is an amazing, it's not too long, it's not complicated, but it covers all the salient points of all of the studies. And it talks about the 25 studies that have been done between, when were they done? Let me think. It was between 1980 and 2013. There were 25 studies that were done in women post breast cancer and on HRT. And there's only one study out of 25 that shows there was possibly an increased risk. And it was a very short study. It was a very small study. It was only 463 women, which is a very, very small sample. And it was only for 2 years, and it was prematurely stopped because they were worried that there was an increase. It was in 10 different locations, so 10 different centers for the study. Each center used different HRT. I mean, it really was not what, if you were sitting down and designing a study, you would not design it to be like that. So they had different HRTs. Some of the women who were supposed to be on HRT didn't take it. Some of the women who were not supposed to be on HRT took it. So the whole thing was a bit of a mess. And so that study actually showed that the women who had an increased incidence of contralateral breast cancer, or on the same side, localized, it were women who were on tamoxifen as well as the HRT. So, so the women who were just on the HRT only, they didn't show an increase in the habit study. So it's very important to analyze all of these things, and to read the article, I think, is very helpful. Yeah.
So what I'd like to know from you is, because I'm sat here opposite clearly this incredibly passionate doctor and patient, to really understand what's going on, what are the studies, how can we not just treat a symptom, but really help the whole person. But many people might argue you're a private menopause specialist, and you use a lot of your knowledge over decades of working with women and hormones, of course, of why you came to the conclusions for yourself. But what I want to know is what happens out there in the bigger, wider world when you worked with other teams at other hospitals. Is the message very much like absolutely no, categorically no, you've had a history of breast cancer, you cannot have HRT? Because there are many messages out there, and that's what a lot of people say. What happened in clinics that you worked at, Chelsea and Westminster? Have you ever given HRT to any other breast cancer patient, or is this just an experiment on yourself for you?
Yeah. Okay. So it's a good question, Danny.
Yeah.
So when I worked at the fantastic clinic at the Chelsea and Westminster Hospital with Professor Nick Panay and his team there, we saw many, many, many women who were post breast cancer coming to the clinic for advice about HRT, and the vast majority of them went on to HRT after a full discussion about the sort of benefits and risks. And it's, it's a specialist menopause clinic. It's where all the sort of more difficult cases are sent, and the GPs were very appreciative of the support of the clinic, talking to these patients who they really, bless them, didn't know quite what to advise or what to do with them. So they would come to our clinic, and we had hundreds of patients, literally hundreds of patients, who were post breast cancer on HRT and were fit and healthy, and we monitored their progress, and they all did really, really well. So it was there that I really saw it in practice. So it wasn't just me doing this work. And I still work with Professor Panay at Hormone Health at his private clinic. And again, we have many, many patients who are post-breast cancer who, after the discussion and reading the papers, make a positive decision to take HRT. And we help them, with the information and with their decision making, and then support them in their decision. So yeah, and my clinic is the same.
My last question to you today, Tina, is who holds the risk? Is it the patient or the doctor?
That's a very good question. I think that we doctors are supposed to be facilitators, and we are supposed to enable patients to make the decision for themselves. And long ago, it was much more of a patriarchal kind of, medicine was patriarchal. The doctor would tell the patient, do this, do that. And that thankfully has gone a long time ago. And now it's very much a relationship with the patient. It's very much a contract of proper, honest discussion with all the information that you have. And sometimes the information is limited, that you might be talking about something where there isn't so much, data, but you do the best to present what is available and any changes and updates in that as you go along to the patient, and enable them to come to a decision for themselves and respect their decision. And even if you may think, if that was me, I don't think I would do that, that's not really relevant. We have to respect what the patients are doing and what they want to do, what they want to have, having given them the facts. I think that's where we're at now.
Thank you for everything you have done for women in terms of their contraceptive health, because I know it's been a game changer. I've got 3 teenage daughters, and I know I'm going to embark on all of those questions very soon. I'll be knocking on your door. And for opening the conversation for all women to just maybe dare to ask the question, Tina. Thank you. And it's been just wonderful to connect with you today. Thank you.
It's a complete pleasure. Complete pleasure. Thank you for inviting me.
I hope you found episode 3 on for our HRT After Breast Cancer mini-series super interesting. I have stopped and started this conversation when I was listening and watching back numerous times to really digest what Dr. Tina Pierce was explaining. I hope you will do exactly the same. We know HRT After Breast Cancer is a very emotive conversation, and we also know it's very personal to you and me and everyone listening and engaging in this conversation, how we handle it, what our thought processes are. If you remember back in episode 1, we spoke to Dr. Leila Agrawal about all the evidence, the studies, the trials that we have to date. In episode 2, Professor Richard Simcock talked to us about how to move forward, who holds the risk. On today's episode, we heard from a doctor who's also the patient on why she decided to use hormone replacement therapy for her particular type of breast cancer, and how she manages and navigates this, the conversations around it. And we know also that a lot of you at home will be listening to all of these conversations thinking there is absolutely no way, even if I know HRT after breast cancer might increase my risks by a tiny bit, I really couldn't even go and think that way, then please honor that. That's totally okay. We're having these conversations because so many people are curious and they're feeling that they're left on their own, not knowing where to go. And that is why I want to bring in a whole pool, a whole team of great doctors and specialists to help us look at it from all different sides. It's no good just talking about it from the patient's point of view. We have to hear the doctor's point of view. And I think Professor Richard Simcock really did that really well in explaining how doctors might feel. And on today's episode, we've sort of taken that a little bit further and heard from a doctor who's also the patient who's decided to go on HRT after breast cancer. And so we're slowly sort of angling our way forward to widening and broadening our understanding of this complex topic. On next week's or the next episode, I'm going to bring on Dr. Louise Newson, who many of you know, who has been prescribing and is prescribing hormone replacement therapy to her patients. And I want to know from her what her thought processes are, how she feels to maybe be called a maverick, and what she's up against. And I can't wait to have that conversation. So please join me, and at the same time, honor your feelings. If these conversations aren't right for you right now, then switch off, tune out, and maybe come back to it at another time. But for now, thank you for staying with us, and I can't wait to share the next episode with you.